share the screen.
I like Raghav's setup. He looks so professional. Like he looks like a podcaster, you know.
Yeah.
This is
Same
my
with Irene.
gaming. It's my gaming headphones.
Yeah, the thing with Irene is that she also matches her dress and everything with the headphones. So it's even
And
one step higher than
Yeah.
Raghav.
and
One
the
step
Yes.
nails. Wow.
Yes.
All right, Raghav.
So I'll just drive around and give you some history in between. Elderly man had a biopsy-proven diagnosis before, and then on imaging, it's a ground glass lesion. I can say 2.5 centimeters because it falls less than 3 centimeters.
And what is
And
this, Raghav? This must be a wedge, right? They wedged it out. This.
correct. They wedged it out, and we just took a piece because we did not see any grossly identifiable lesion. So whatever we found, like a tan fibrosy looking area, we
Yeah.
just sampled that, and we carefully palpated in the wedge specimen to see if we're missing any nodules, because this is frozen section, so you have to do it quickly.
Right.
So we tried to palpate. There was no other nodules. This was the area which was feeling little firm, and we freeze that area, and this is what we see. Um, so most of the areas, you can still see the alveolar architecture like here, but some areas you can see this little expansion of the interstitium. Otherwise, you can see the cells lining on either side of this alveolar septa. But still you can make out the alveolar architecture. But some areas are like this, where you see more of the fibroelastotic stroma. And then you see some rounded structures. They could still be alveolar spaces, but
Some little metaplastic bone there too.
yeah, metaplastic bone.
They saw a lesion. How much measured that lesion? I mean,
2.5 centimeters ground glass lesion, entirely ground glass. Uh, they mentioned, like at the end of the comment, they mentioned like 2 to 4 millimeters focus of solid component. And then you have these kind of areas where there's some rounded glands. Otherwise, if you go on higher power, the cells are lining and they're a little bigger, but otherwise I can still see some gaps. But again, it can be different people can interpret that. Some people might say the stratification. Some people, you can see there's still some gaps in between those cells, but other areas you don't see gaps. So how would you want to call this unfrozen section? Do you need any other additional information?
Nope.
Okay. Reactive adenocarcinoma.
All right, we've got the whole spectrum here. All three.
Yeah.
Yeah.
I think I'm scared it is an adenocarcinoma, but I would be more scared of saying adenocarcinoma in the frozen. I don't know.
It's a tough one.
It's
a tough one.
Actually, he's picked a good case because it's bland enough that the whole spectrum, you have to think of everything. So it's really a question of, when you see this, do you think that something reactive could look like this or not? That's really the main issue here.
It seems like in areas there's kind of a sharp cutoff with the adjacent.
That's what I look for when I want to say adenocarcinoma. I look for the difference. Normally there is a difference with the rest of the parenchyma, and there is no. But
Raghav, can you show us the edge of the lesion, like where this thing interfaces with the normal lung? Yeah, like up there.
Yes. Yeah, that's a very good point, because I generally try to see that because you can see here, that's the normal looking remaining lung. But here you can see the interface where there are some smaller glands and getting into this fibroelastotic stroma, where it's almost like forming an acinar kind of glands. Otherwise,
this area is so scary. this area is super scary. Here,
Can I ask you guys a question? So, I think people are afraid. I think there are two issues here. There are two issues. One is that it's not clearly invasive the way a colonic cancer or something would be, right? I mean, where you would have stromal desmoplasia and lymphatic invasion and this and that. Like, it's not a clear-cut invasive case. And many lung cancers are like that. We know that. The second problem is people are afraid of this whole lipidic issue because they feel like if they say adenocarcinoma on the frozen and it comes out and it's an adenocarcinoma in situ, or a minimally invasive adenocarcinoma, that they will be wrong and they would have overcalled it. So I would like to hear what you guys think about that issue. So first of all, how do you call something cancer when there's no clear-cut invasion, stromal invasion of the kind we see? And second, are you worried also about this issue of that you will that adenocarcinoma is not the right thing to call it if it turns out to be something else?
Sorry, I said reactive, but I wanted to say atypical suspicious or something like that. That I haven't seen enough to be sure it's cancer. I don't have this issue that you mentioned, Sanjay, because in my institution they remove also in situ.
Mm-hmm.
So this takes this problem from me. They want if it's an adenocarcinoma, this area is super scary. If I say adenocarcinoma, they will be happy to.
But what I'm asking, Irene, is let's say you get a frozen, right? You say adenocarcinoma, then you look at the permanent and you go, oh, it's all lipidic. There's no invasive here, so I'm going to call it adenocarcinoma in situ. So were you wrong on the frozen?
No, because I said adenocarcinoma and it's in situ.
Yes, but I think some people think that this is wrong in the same way that in breast, for example, it's a very big deal, right? Invasive versus DCIS is a completely different thing. They don't understand that in the lung, it's not that dramatically different.
No.
Between adenocarcinoma in situ and invasive.
No,
that's really the issue.
Morphologically, it's not that different, and the problem is that if your surgeons handle it differently, it's a mistake, because the purpose of doing a frozen section is to lead their management.
Yeah, I think the other issue that slightly goes into that is, again, some people have heard in the on meetings and this and that if it is an adenocarcinoma in situ, maybe they'll do only a wedge resection and stop there. That's adequate treatment. Whereas if it's an invasive adenocarcinoma, then you'll move to lobectomy. And I think I'm not sure, because this doesn't happen at my institution, but there are places, I think, where they might use the frozen to make that decision. So you say that this is all lipidic and it stays, and you say it's invasive and it comes out. But I think that's a very big mistake to do that. But I think that's also why people are afraid of this issue,
Yeah, I generally, whenever I see lipidic features anywhere in the core biopsy, again, that's a different discussion, but let's put it on the frozen section slide. Yeah. In this case, I would call adenocarcinoma, but I would call the surgeon and say, I see areas of lipidic growth pattern, so which can be seen in a spectrum of lesions from adenocarcinoma in situ to minimally invasive adenocarcinoma and lipidic type of adenocarcinoma. But for that, we need to sample the entire lesion to find out how much the invasion is present. If it's less than 5 millimeters, minimally invasive, more than 5 millimeters, invasive adenocarcinoma. I also tell them other non-lipidic growth patterns. They generally know what I'm going to tell because so far.
So do you say all of this at the time when you call them, Raghav? Like
No. I try to keep it very simple. In situ versus minimally invasive versus invasive. But the top line would be adenocarcinoma. That's it. Many times that's it. That's all they want. And many of our surgeons, they're kind enough. Means there's not. That's not. It's about practice. They come to the pathology lab, so we are lucky enough to have the discussion.
Okay, Matt, how does it go at your, do you have this issue about calling these?
No, they're usually pretty happy with us just saying it's in a malignant spectrum. Sometimes I'll say at least lipidic adenocarcinoma, depending on the size of the lesion. But you're right. It brings up, well, what if it's just all in situ, right? Then it's AIS, right? And
yes. What do you think about that, Matt? So what happens if you call it adenocarcinoma and your permanent is AIS? Is it wrong? Was the frozen wrong?
Well, it's subtly wrong in a way, right? It's a change within, threshold, right? But that's it's not really something that you can assess on frozen, right? Because you need to know the size of the whole thing and everything, right?
Yes.
But yeah, and I think this is where looking at the imaging and stuff can be helpful, right? Because if you know it's over a 3 centimeter thing, then you're safe in a way, right? And if it's a really small thing and I'm only seeing a small area of it, then I'd probably back down a little bit.
Yeah.
Just to.
Correct. I think that the reason that I bring this up is I think there's a different approach if you think that this is not a legitimate call to make on frozen section. In other words, if your premise is that this distinction between AIS and MIA and lipidic predominant is not something you should be doing on frozen, then the practical way to handle it is call all of them adenocarcinoma and then do the subtyping on permanent.
Yeah.
So in a way, it's a compromise to be able to make a practical decision on the frozen and handle the nitpicking to, defer the nitpicking to permanence.
Yeah, agree.
That's one way to do it.
I agree completely. I guess the only thing is just knowing that your surgeons realize that when you say adenocarcinoma,
exactly,
that includes in situ disease, right?
Exactly. Yeah. So, anecdotally, our surgeons this has never been an issue here because our surgeons do, lobectomies for all adenocarcinomas. And if they think that something needs a sublobar resection, that decision is made based on imaging findings, not on frozen. So we are not the ones driving that, wedge versus lobectomy on frozen.
You already convinced me it's an adenocarcinoma.
Was that Irene?
Raghav may show these areas of so scary that I'm already convinced it's an adenocarcinoma.
Yeah, because whenever I see these glands making some round kind of areas, round structures, and then they have this more distance between each other, that's when I start to think about acinar growth pattern or non-lipidic growth pattern. And I try to look for it, and I tell all my residents to look for those no matter where. And again, the issue to go into core biopsies, where we generally see lots of core biopsies, they always show it to me like core biopsy with lipidic growth pattern. What should we call it? Should we call it same question, adenocarcinoma, or give the differential diagnosis? So, which we have already discussed, kind of touched upon. So I called it adenocarcinoma, and then after that, we did have non-acinar growth pattern areas. So I think it became invasive adenocarcinoma, or I think this one became adenocarcinoma, lipidic predominant adenocarcinoma, because the non-acinar, non-lipidic part was small enough, so still became lipidic predominant adenocarcinoma on final sections.
Yeah, I mean, two issues here. One is so on the frozen, to my eye, this is invasive. The cytologic atypia is too much to be. Through lipids. But again, you show it to any pathologist and any second pathologist, they will have completely different ideas about what is lipidic and what's
correct.
That's one issue. The other issue is, Matt, so you have this like rule of thumb that your mentor taught you, right, about how to tell. Can you just
yeah, sure. So if you stop in an area, Raghav, so my mentor, Marcio Gomez in University of Ottawa, taught me this trick of sorting out whether it's papillary or lipidic. And so here's our ice cream cone. I'm not a very good drawer, and so you think you're a person on this side, and I really want to get to that ice cream cone. And so in lipidic, you can't, right? So I get stuck here, right? I get stuck here. I get stuck here, right? But in papillary, because the architecture is actually disrupted, you can actually get all the way to the ice cream cone because the walls are actually destroyed. It might be a bit convoluted, but you can get to the ice cream. So if you're struggling between lipidic and papillary, just ask yourself, can I get to the ice cream?
Ice cream cone.
It's so funny.
Yeah, interesting idea. It really is. I'm going to try it on my next one.
Yeah, you can try if you don't like ice creams, you can also try different foods, Sanjay.
Actually, I'm going to say that to my surgeon. I'm going to say, I thought initially, but it was lipidic, but I could get to the ice cream cone. So.
Oh, that's funny.
Very cool. Thanks, man. Okay,
Thank
so
you.
yeah, Raghav, great case. Really, very relevant.